Okay, so in this session, we're going to review the toolkit that we've been discussing throughout the conference, and so that all of the materials are in that flash drive. So we'll review the contents of the flash drive, and then we'll also give you a demonstration of the website and where you can also access all of the different resources, and where you can direct staff or your coworkers to also access the resources there. So do you want to go ahead and... We should do some introductions. So I am Esmeralda. I'm the project manager for the CPIC study, and I will be co-presenting with Mariana. We've been working on this website, and we hope that it'll be user-friendly and that you will be able to find helpful resources there.
I also want to introduce Jim and Elizabeth, which you've met already, and they'll be doing an activity at the end. So our presentation will go from briefly reviewing the contents of the flash drive, which you just received, to doing a short demo of the website and looking at how to access resources and share those resources in your agencies, to then discussing the collaborative care model with Jim and Elizabeth and doing an activity about trying to visualize what pieces of collaborative care exist in your agency today, which pieces could exist, and which pieces you think you'll be.
I'm Jim Gilmore. I'm Director of Corporate Development Training at Behavioral Health Services. I'm here because Mariana made me. I'm on the steering committee for CPIC. I'm very involved. For many years, I was the chair of the Substance Abusing Mentally Ill Task Force here in Los Angeles County, and I've always had an interest in co-occurring disorders and folks with mental health issues and substance abuse. So this was kind of a natural project for me to be involved in. We also, BHS, has been piloting the BRIGHT project, which you saw mentioned. We've been working with RAND in doing a project using BRIGHT for the last 4 years. So that's why I'm here, I guess.
Esmeralda is going to talk about the flash drive. The flash drive contains what we've been calling so far the Cbt Toolkit. So get to see what it is. And it's the first page on your handout is a table of contents for the flash drive.
Okay, so does everybody have their flash drive? Everybody, that's kind of your surprise little present is the flash drive.
Yes. So in the flash drive, there's a variety of resources. And so when you open up, you'll see this CPIC resources for agencies. And we have a folder with articles, and basically all of these articles are listed on the back of your one page here. And they are articles that that talk about the different projects that happened before CPIC, so Partners in Care, and there's very informational articles on collaborative care and just some community updates that explain the study and the history behind the study. So a lot of what Dr. Wells and Elizabeth spoke this morning, and we also have the book that you have in your handouts. We also have it as a PDF file, so if you'd like to share it with someone at your agency, you're free to copy that or pass it along. So we have the book there, and there's also some depression slides, and these are also very helpful. I guess if you're talking to a friend or a client, and you want to just cover some of the basic symptoms of depression and some of the different options for treatment. We also have in this flash drive a care manager toolkit, and we have a guide for the care managers and a variety of forms that can be used when you're doing your sessions with your clients. We have a Cbt Therapist Toolkit, and this is where we have the Cbt manuals, which cover the BRIGHT program, and we have these available in English and in Spanish. And these therapies can be done in an individual session or in a group session. And in the open session, members are welcome to join at any module of the program. So there's 3 modules: the thoughts, the activities, and the personal interactions. So if you're having a group, people are welcome to join at any module. I'm sorry? Oh, sure. So,
Okay, so
the group, let's do the group at open group leader.
the open group.
Uh-huh.
Member, not leader.
Either one is fine. Open group.
Okay, who's the open group leader?
Right. So you'll see that that this is an introduction for the leader. So it explains to you how to use the manual, and then you actually have a leader guide with some tip boxes for each session guiding you. And then there's the members workbook, which you can give copies to your all of the members of your group. And so, like I said, the open session, anybody can join. The closed session is when you want to have a focused group for the full 12 weeks of treatment. And so you would go through the entire 12 weeks without having other members join, intermittently. And so those are available, like I said, in English and Spanish. They're very, very wonderful therapy manuals developed by Dr. Jeannie Miranda, or catered by her. And we also have some forms for therapists in this toolkit. And the can you go back one, Mariana? Sure. The contents of the toolkit, that document explains to you or shows you all of the various forms that are in this packet. So those are all the Bright manuals, and then we have all of the forms listed here. So getting to know you, post-evaluation, just great resources here. And we also have a clinician toolkit. So this would be for, MDs, nurses, nurse practitioner, anybody in primary care, but it can also be used by case managers and outreach workers. It's a great resource. It covers, some of the basics on assessment and evaluation, right, of depression. So
It's on a medical model, so we understand that not every it was written for primary care providers. It follows the medical model, so we understand that it's not applicable to every provider. However, the assessment algorithms are very helpful, and I think it's also helpful for case managers because oftentimes their clients are not seeing the primary care providers often, but in the case managers are helping, really the provider helping the client is stay in treatment and keep up with the treatment plan. So it's helpful to understand what kind of treatment the client is undergoing, what their medication is, what are the possible side effects of that medication, how soon is it advisable that the client comes back and talks to a primary care provider about changing medication. And all of this is covered in this Clinician Toolkit.
And there's additional materials for administrators. Jim, do you want to just briefly cover some? We have the levels of engagement piece that you wrote, and we have the training agendas and training materials for teams, which Elizabeth and Jim will do an activity and exercise with us in a little bit. So we have materials for administrators, and then lastly we have we have some patient education brochures, and those were in your bags when you got here, the Spanish and English brochures. You can print those out, hand them to clients. They're informational. They cover the symptoms of depression, what are the different treatment options, there's hope, there's help, there's treatment available. And so those are there for your use. And we lastly have, which one was the very last document? The user guide for partners in care. So that one, it covers the previous study, which was the parent grant of the Community Partners in Care study, and it covers a little bit more about collaborative care, and it has.
This is the activity we're going to do today, so we don't need to spend too much time.
Is that the user guide? Okay, great. So it's very comprehensive toolkit, and if your agency needs a specific document, if for example, the CBT manuals, we might be able to make some extra copies available in print, I think, right? So.
For somebody whose first computer had like this little floppy disk with like 1,000 kilobytes on it or something, I think this is really amazing. Now, there is so much material on this little flash drive. It's just awesome. So it's really an excellent resource in terms of all different aspects of this issue.
Well, the idea is also, remember how I said nobody leaves with nothing? So everybody leaves with something of value. And this could be very valuable to you. So what you do with these, they're all blank, and we're not telling you how to use them. You personalize them according to the needs and the requirements of your own agency. So if you're working, there's some cultural considerations you need to make, and the toolkits don't look quite right to you. Maybe working with Armenian population or something, and you need to make some adjustments. That's what you do. It just provides you the foundation to implement a collaborative care program in your way, in your program. So it's pretty remarkable. And I went to the SPA 6 conference. And they hand out these flash drives, and so I'm an administrator in a program. I'm like, wow, a book and patient education. I can print it out. It's all in one place. So. And it took them hours to get that stuff on each of those flash drives. These two, the foundation. So I think it's a really valuable resource. And I know we kind of went over all of that really quickly, but there's a ton of materials on there.
Right. And so these exact materials will also be on the website. So if you want to hang on to your flash drive and just keep it with you, you can...
Yeah.
You can direct your staff or coworkers to the website, and they can also access them.
When we're doing the community engagement arm training, in that arm we're going to be training therapists from agencies that get assigned to that arm in being leaders in CBT. So that will be videotaped, that training. And that training would then also become posted as something available even to the resources for services. So even if you're not in the arm getting the intrinsic training, you would have access to, your agency could, in essence, be trained, because it's very expensive to purchase a trainer to come to your agency. But even if you aren't in the active arm, if we're able to accomplish that, then you will have, in addition to the manuals, you will have access on the website to the actual training programs if your agency decides to use them through the web. So that's just an example of how we're going to try to make sure that if you have the motivation and interest and need to use them in your agency, you
Okay,
can.
so I think we're going to step back because we covered the resources.
Are there any questions? Does anybody have questions?
These are not copyrighted?
They are copyrighted.
They are copyrighted.
But we have permission to use them for the purposes of the study, including your downloading them, printing them out, and so forth. So even, I don't know if you touched, but for example, even this Beating Depression book, which is a resource on the flash drive, we have permission for the purpose of the study from the publisher to do that.
Uh-huh.
And the copyright on all the Partners in Care toolkits is owned by RAND, and RAND has given us permission for this kind of dissemination purpose.
Uh-huh.
So you can print them out, you can use them. You'd normally be paying for them.
Yeah.
But, and even if you're not in the study, because we've given you these flash drives, if you end up not being in the study, you have access to these materials, because we're trying to make the overall study a win for the community, even if you're not participating. But if you are participating, then we will support you in studying these and using them and figuring out how to use them in your agency.
Yeah, well, I'm thinking about it in terms, we have a mental health library that is accessible, one-stop shop for all our staff to come to the one place and get the information, right? And my hope would be that this would be able to be integrated into that mental health library, you know, to get access to 200 people, you know, rather than them each always having to go back in and accessing the web and each always having to remember their password and remember their...
Right.
We support that idea.
Yeah, but you could have, for example, your library could have a computer, probably does. I don't
Yeah,
know
it's
if it
all
does,
computer.
where your agency could have a password to get access to this site.
Yeah, we could link,
and they
for
could
sure.
and then they can always have at their fingertips that information.
Okay, so linking to the site wouldn't be a problem for you.
Well, that's it. I see what you're saying. Linking to the site, you will have a password specific to your agency if you're a participating agency.
Okay.
In the dissemination phase of the study, after the trial,
Uh-huh.
then the site will be available broadly. But during the trial phase, when we're trying to get the outcomes data on this community approach to doing it, then you would be a participating agency to use the website. Am I understanding this correctly?
Well,
Isn't that
everyone
how it
who's
is?
here today is getting access to the site. So either a participating agency or someone who's here today. Because everyone who's here today gained access to it.
Okay.
I mean, DMH is here today, but DMH is
It's
like,
everywhere.
I mean,
Right,
DMH
right,
is big, right?
Right.
Yeah,
Well, they're part-
we
they are
are
part-
committed to ensuring that we adhere to the laws and wouldn't want to breach a copyright infringement,
Right.
you know, so that's the point of the question.
These are copyrighted materials. They are available under special arrangements for purposes of the study. To be honest with you, I haven't really, and I think that would include the broad community engagement purposes of the study. Beyond participating sites, we can look into the letter of the law on that. If you end up being a participating site, I know for sure there's not an issue, because that's the specific arrangement that we have. And some of them, the book, for example, we'll have to renew it in 3 years or something like that. But then you're going to want some other book in 3 years. So, but that was all part of setting up the study, and trying to make it a win.
marvelous.
I think I kind of created the problem a little bit, is that it's important to me this is a community conference open to everyone who's interested, and instead of just being for CPIC agencies. So being open to everyone, we can't say, oh, here you can have it, you can't. So, I think today everybody gets it.
Well, we do hope you'll be interested in this.
But of course, yes, the bottom line is we'd like you to participate, and we hope you think you do better in the project than on your own. So, but part of it is making it open and accessible to the community.
Well, and it seems to me like that is one of the frequent problems, that things get done still in a silo. It's on my web versus
Right.
the web that my staff use, so I think, again, there's still these silo processes that occur unwittingly, that it's not, it's not done in a way that makes it,
Yeah, I mean,
impediments
just
occur.
to reassure you some, even the CBT manuals are already available for free download on the web. All of the partners and care materials outside of the study, like the care management, not our version of it, but the one that was used in the study, you can get for free on the RAND website. What you can't get for free is the hard copy set, because that just costs money to produce. So you have to pay just cost only from RAND. So that's part of why it was so easy for us to get permission. The only exception to that is the book, which is a commercial publisher. But they agreed basically to take RAND's point of view for the purposes of this study. So we're just trying to make it as easy as possible for people to use clinically sensible material.
Right.
Yeah.
And one question.
So are we saying with registered users, there's no screening process, anybody can, just like you did a while back?
We have the registration open right now because we want folks who come here today and who are participating in CPIC to create their own accounts. And then, in a few weeks, once we feel that as many people from this conference registered that we would register, we would change the site to registration where if anyone can request access, and then we'll screen and provide access. But to facilitate everyone who's here today and everyone who's in your agency, your partners and your employees, for them to have access, and I think it's important that they create their own passwords, because otherwise folks won't remember and they won't come back. They'll just leave the site.
And the aspects of it that are specific to the study, like the telephone support calls to help deal with the agency, will be limited to participating sites, just because we don't have the resources to support, at this point, to support the whole community. So that we'll have to figure out, does that get on some, we'll have to figure out exactly how to engineer that. But the intent is that portion of it are for agencies participating. That you still have the toolkits even if you're not. So, okay, is that clear enough? Yeah.
One last interesting point, since you brought up copyright. Sometimes something's copyrighted, but it's available for free. However, you can't modify it. That's not the case for all the resources that are modifiable. We have several forms. They're in Word format. And the reason they're in Word format and they weren't PDF is because we want folks to come, download it, bring back to their agencies, and make whatever adjustments they need to make it work for them. So even though those are copyrighted materials, they are modifiable because we hope we'll make it our own.
So we're going to talk about adapting. This is really important, is adapting collaborative care forms, models to your own agency. So what do? You've got this great resource. You're going to take it back, and we're going to talk about what components might fit at your age, or you have already at your ages. Maybe you never even thought of them as collaborative care. What's working? What could be improved? What could be strengthened? Yeah?
Real quick, one of the things that Esmeralda had mentioned before, in your flash drive, there's a section on administrative issues, and there is a little piece in there called levels of care, which is really important in terms of, in the very beginning, it's kind of important to know that everybody in your agency, everybody that's participating with this is on board. So sometimes we forget, the administrator may know what's going on but forgets to tell anybody else. The middle manager may know because they're the ones that are attending the meetings, and they don't tell the administrator or they don't tell the receptionist. And usually the receptionist is the last one to know about anything. So in this levels of care, it's on the flash drive under administration. It kind of talks about the various issues that each level of employee in your agency should be aware of, so that when someone comes in, no matter who they talk to, if it's the receptionist at the front desk, if it's the manager, if it's the CEO, whoever, everybody knows what we're talking about here and knows who to refer someone to. And hopefully even the receptionist will know enough about depression to recognize signs and symptoms and be able to, from their desk, make some kind of referral. So,
I think that's important. One other thing is we didn't really tell you. You know who we expected in this room? We expected the administrators to come to this room. In the SPA 6 conference, this was the administrators section. They didn't go over the flash drive like we did here as much, but we recognize that in caring for clients, if you run programs, if you're an administrator, there's special concerns. And so, it's important that we've got the providers learning the CBT, we've got medication, the field people learning about the medications that work. And so we're kind of the supportive administrative component. Now, I don't know, do people have a copy of this in theirs?
Yes,
Okay.
it's in their packet.
If you take out your packet, you're going to get a handy list of collaborative components of collaborative care. And we're going to just think together about
It looks like this. And,
it's how 8 different agencies can work together to care for depression. Okay. And if you turn to page 3, you don't need, we've talked about collaborative care probably enough today that you don't need to, maybe I will sit down. You don't need to read through that whole thing. Clearly there are different components of a collaborative care model for depression. And I just kind of want to have a discussion about, think about your own agency. Maybe we can shout out about the 3 components. Let's identify a few components that are going well for you at your agency in terms of collaborative care.
Does everybody do outreach, for example?
Okay, I'll tell you about the nurses again. Love my nurses. So, nurses working out in the community. And they, the outreach and the trust building in the community has been really important. I think they're great screeners for, they can sense, that's that intuitive sense when someone walks in. They may walk in and say, oh, my problem is high blood pressure. And the nurse will attend to that, but it's that kind of intuition and the screening that something else isn't quite right. So that screening for depression, and they do have access to the standard tools to screen. But I'd say their screening is good just by their intuition alone. So I'm proud of them for that.
Do they have access to things like assistance in other areas as well? I mean, are there links, like if, yes, somebody's depressed, but it seems to be an underlying problem that they're either homeless or unemployed or whatever,
right.
So they can link them up that
Right,
way
but
too.
it's yes, we have, so the nurses working out of the community, we kind of are the resource scavengers as well. We know what works right now, what clinic is open, what's taking appointments, what takes 6 months to get, where can you get, what's the nearest food pantry. So we do know that, but it's all informal knowledge. So I feel good about CPIC because it'll formalize that knowledge. I mean, we don't have to keep scrapping all the time to go see what clinic is open for appointments so that we can race to get it. So
We have a system in Palmdale. We invite community resources to present to us, and we do the same. So that in our little community, we kind of pretty much know what its other offers. Like when patients come in to me, they're 18 years old, and then I know that they have medical. So I give them an option. Either you come here with us, or you go to Mental Health America and their TAY program. So that kind of thing. We educate the public in what resources are and what are the resources available that's easier for them. And then they will present, well, I'm also homeless. What do I do? And I also need food. Okay, all right. Oh, here's the list. So you're on your own now. I mean, we kind of tell them. And then we tell them that if there's nothing else in the list, call 211. You know, that kind of thing. Help them navigate the system. Okay, I don't have voucher. I don't know how to. I'm new in the area. Where do I get, transportation support? So those kind of things. We don't necessarily deal with mental health only. It's the whole gamut of life. Meaning apartments, housing, food, domestic violence issues, support groups. There's somebody who's in grief. Then we tell them there's a chapter of Compassionate Friends here. This is the meeting time, that kind of thing. And we have a resource book in every room. So anything that presents itself, here it is, kind of thing. And it's up to them to kind of navigate the system.
Well, the problem with those resource book, anybody ever use the Rainbow Directory? By the time it's published, it's no good.
We actually update it.
Yeah. Update it, but things change on a weekly basis, right? So it's really that word of mouth on the street, what works and doesn't. Like, I'm so happy to hear about your program that at USC that hadn't heard of that before. So that's what Mago investigate. But it's always listening carefully, investigating. So anyway, So that kind of outreach and referral, those are components of collaborative care.
I would say that Children's Bureau has done a good job in outreaching around child abuse issues. However, just like in the day where people all knew that substance abuse was a problem, they also knew you couldn't get anybody in anywhere, and so they stopped evaluating it, because once I knew it was a problem, I had a responsibility to try and do something about the problem that I saw, right? And so, I mean, kind of as a field, people just didn't evaluate it, kind of, you know, no eyes, no mouth, speak no evil, hear no evil kind of thing. I don't think Children's Bureau does a great job in evaluating the depression of the adult caretaker coming in, partly out of that same reason, you know, that there just isn't, again, a resource to refer the moderately or mildly depressed parent to, because Medi-Cal wouldn't pay for it. So, you know, I mean, I do see some assets there, but it's hard for me to think of the assets with the magnitude of the problem in front of us.
That same issue came up in SPA 6 when we were doing this, and the very same thing you mentioned, that folks may be aware that folks are suffering from depression, but because there's so few resources, it's not really assessed, it's not really referred. It's kind of like we just kind of have to, you know, that's the way of life. That's the way it is around here, kind of thing. And I think that's what we're looking at in terms of collaborative care, is we're really hoping that we're going to open up some resources to folks. So part of this is the education process. It gives you, you know, the folks that are going to participate in this, some tools that are in the flash drive and stuff to kind of recognize what's going on. And hopefully we start looking, even though there's not, you know, per se, you know I can't refer somebody over to mental health. They're not going to be seen. They don't have Medi-Cal. You know, that's not going to happen. But we're hopefully developing some other alternatives that we can use. We talked earlier today about faith-based issues. We've talked about the CBT, that we're going to hopefully be training some folks in, that will be an alternative and a resource for folks to use that are part of this process. So we're going to try and kind of develop those resources. But again, just the fact that when someone comes in, you don't just go, oh, well, I guess I'm not looking at that, because, you know, we can look at it and hopefully make some kind of referral, knowing that we're part of CPIC. You know, we can send them somewhere. You know, who knows? Again, we're all dealing with the shortage of resources, but just the fact that we're all looking at it, I think, is going to make it a little better than it has been.
So that's the only session, right?
Yeah, it's only one.
Yes, I had a question. We see a lot of clients coming into our clinics and into our counseling area, and we sometimes find ourselves looking for clinics or places who can see them for schizophrenia. And so my question was, I know that there are clinics out there that sort of specialize in some areas of mental health, but is there one for, or some for, schizophrenia?
Actually, severe mental illness, you're better off than low-level mental health problems.
And adding to that, the way I seem to be finding them in the community is as I go out and visit elders, you know, kind of just checking in on them, I'm finding more and more adult children coming back to live with their elderly parents, and they're, well, you know, I think I'm, you know, schizophrenic grown children. And I don't know what else may be going on, but perhaps a history of drug abuse and alcoholism, whatever, but the schizophrenia does pop up.
Right. Now, as I said, I mean, you probably all know more about that than I do.
Well, I would just respond that this project is really about depression, but establishing networks like this kind of gives us more resources for all of these things. I mean, if I have contacts in the community that I know I can refer mental health issues like depression too. I can probably also know that there are some of those folks who will deal with schizophrenia or bipolar issues or whatever. So it again, the whole concept of this collaborative care is to kind of build that network so that we all have more resources. There's not going to be more money coming down. There are not going to be new clinics opening. But there's things that people are doing. Like you say, there may be a clinic over here that you don't know about or that we don't know about that's doing something, and perhaps if they were brought into this network, then they might be able to take one or two people. They're certainly not going to take everybody, but, little by little we can kind of improve the resources. And that kind of happens kind of as a byproduct of this focus on depression. But I personally look at this because I work in the substance abuse field. We also do mental health co-occurring disorders. But I look at this, and it's something that I've been working on for years, is trying to establish as much collaboration as possible, because the more of us that work together, the more options that we have. And the stronger voice that we have, if there ever is any more money coming down, that we can, as a group, kind of approach folks and say, look, these are the statistics, this is what we're dealing with, this is what we need. But, if we're doing that individually, it's not as effective as if the community says, hey, we want this.
Well, why don't we move on to the next? What could we do better in collaborative care? Think of your own program and your substance abuse counselors. What could they do better? What do you think they'll get out of CPIC?
Well, one of the reasons why we look forward to being involved in this, it's actually kind of twofold. One is just the networking, as I said before, the being able to know that there are other resources out there and people offer other things. We also run into a situation periodically where our services are not totally being utilized, for whatever reason. Sometimes, like in the summertime, people don't want to come into treatment because they're too busy going to the beach. And all of a sudden our census drops way low. When it's raining and cold, oh yeah, everybody wants to get into treatment. So, but by having this collaborative and this network, again, and hopefully, I don't know if I'm jumping the gun, but at some point we're hoping to have like a computerized program that kind of lets us know who all's involved. And through this network, we can contact each other, and we can know, well, I have 2 slots open over here, or, we do this. We've opened a program working with schizophrenia if anybody's interested. So, by connecting all of us together, and part of that will be a map. I hope I'm not giving away things too soon. Part of that will be a map, so you can look on that map and know where services are in your area. So all of this brings us, brings that network closer together. Something someone talked about earlier today was the fact that networks seem to work really well in specific communities. But what if we hooked all those networks up together so that these folks could all talk to each other and have the benefit of expanded resources? I think that would be really effective in terms of, at least increasing resources. I mean, again, I keep going back to the fact that times are tough. It isn't going to be like it was for quite a while, I don't think. But that means we need to get even more innovative and more creative and work together more to look at, what is it that you guys do? What is it that you guys do? What is it that we do, that we can kind of share those resources with each other?
Yeah, sharing resources. I welcome any of your clients to come see my nurses. Free. In the community, walk in, no appointment, tell me your problem, I'll figure out how to help you. We're weak in collaborative care in mental health training, so I'd like all my nurses trained in, brief cognitive behavioral therapy, so that as a point of contact when a client comes in, that they can assess better and maybe say something that makes a difference. So they're not ever going to be therapists. I don't expect them to be therapists. But if they had a little bit of training, extra training in what therapists say that makes people feel better, I'd like my nurses to know about it. That's kind of what we're hoping to get out. But sharing the resources, Bring on the clients. We're ready. We're ready to see you. Oh, come get a flu shot, by the way. We'll be doing 5,000 flu shots in Spa 4.
I don't think I answered the
I
question.
should have brought him today.
I don't think I answered your question from before about what could we do better. One of the things, and it's not a direct result of CPIC, it's a direct result of being involved in the BRIGHT program, is that we've realized how effective CBT is, not only with people with depression, but a lot of different issues that folks have. So we're actually going to implement CBT as a standard part of our process, treatment process, throughout our agencies. And we're getting ready to embark on the training process of all our staff. The BRIGHT project was really great. It was very effective. The effects, the outcomes are phenomenal, but it was also all a research project that was paid for. So we don't have the money necessarily to do that. So one of the advantages to us, and I'll be real upfront about it, is that we can get some of the CBT training by being a part of this. That's a good thing for us. And, you know, it kind of helps us go on with expanding CBT as part of our standard operating procedure, which I think makes us more effective with all the folks that we're dealing with. And I can't say no. We didn't really, and I'm not even sure if our results are on the flash drive. They probably will be at some point from the BRIGHT project.
Not from BRIGHT.
Okay, well maybe we can put that on there. But just to say that we're really looking at the folks who've gotten this intervention are doing way better, and actually the people who just go through substance abuse treatment do much better. But the people who go through substance abuse treatment with BRIGHT do even better. And we're talking about 3 years. We're looking at 4 years down the line now for people. And it's just, the results are phenomenal. I think Ken mentioned earlier today that, you know, people could look back 5 years and see that something I did 5 years ago is still having an impact. And we're seeing that now 4 years back, where individuals who've gone through the BRIGHT project 3 or 4 years ago, you know, are still clean and sober, are working, are not getting arrested, are not using the emergency rooms. So there's all kinds of, you know, implications to this that are just amazing.
So do you want to clarify how the BRIGHT project works in substance abuse settings, Jim being the lead partner, and they use the exact same CBT materials that we use in CPIC. So the BRIGHT Toolkit was developed by Jeannie Miranda, who you met today, and Kate Watkins. And Kate took that manual and got together with Jim. They partnered, and they developed BRIGHT for substance abuse. And this is a program that got so many results that got Jim excited with working with us. And we hope that that's the program that will get all of you excited to work with us.
Well, I think not only are the outcomes so exciting, but I think the real exciting part about this is that CBT is usually delivered by a therapist. And what we did with BRIGHT was we actually trained substance abuse counselors. These are not therapists. They're kind of common everyday alcohol and drug counselors. And we trained them to do the CBT intervention with the manuals. We did provide them with clinical supervision. But we're seeing these phenomenal results from folks that we just trained, you know, right off the street, so to speak. So that's kind of what we're looking at with this project is we're going to be able to train people who ordinarily wouldn't get this kind of training unless they're, you know, in postgraduate school or in a master's program somewhere. So we could theoretically train people who, you know, who don't have those qualifications, but that could deliver the BRIGHT intervention. So that's one of the really exciting things about it, I think.
I have a question. Yeah. In the area of this clinical intervention model, how about prevention and early intervention? Is there any aspect of it in CP? like, for families to understand, how do you understand early signs so that, it doesn't escalate to further clinical depression? Any aspect?
Well, I think it relates to that public education piece that people have been talking about, that, when Jeannie said that she had clients who didn't even know they were depressed, they said all their friends are like that, their community's like that. So I think the public education piece of distributing all these, go give a presentation on depression. Let's get the word out there and I think we're getting better able to talk about it. It's a very sensitive, delicate topic. But I think that it's the public education that will matter. And it won't be the therapists or the professionals doing that. That'll be the case managers and the outreach workers who really distribute that message, in a way that the community can hear.
I've just noticed since I've been involved in this that I see about 3 TV commercials a day about depression.
Pharmaceuticals.
And yeah, exactly. But the point is that it's apparently enough of an issue for them to advertise for it. And the thing is, obviously, that's only available to a limited number of people. I mean, not everybody is able to get those kinds of medications. I don't think Abilify is one of the $4 medications. But the fact, that people are hearing about depression, now if they hear that there's some other alternatives to those things they're seeing on television, I know that there's a lot of stuff going on about depression. So it's rising to the surface on a number of different levels. And, this group is actually doing something directly about it and working together. So I think, with the public knowledge that exists, with the training and the education that we can do by putting together these community collaborations that then have influence, and impact on all the folks that they deal with. Because it's amazing, you may be talking about something completely different, but mention that you're a part of CPIC. Oh, yeah, what's that? Or somebody mentions to you, oh, yeah, my dad's really, suffering from depression. I don't know what to do. Oh, why don't you do this? Why don't you go over to this place or that place? So all of a sudden, all this stuff kind of starts to spread around the more that we all talk with each other. So I think that's part of it, too, is it's really rising to the surface. And I think this is a very timely kind of intervention that we're doing here, because there are a lot of things being suggested, but very few of them have to do with the community coming together as a group and addressing this issue.
That's why the White House is interested. This is a big social experiment, right? The White House is interested because this is the first time that the community's really been sought out for their help and assistance in dealing with mental health problems. So this is a really innovative study. And I feel like I'm proud. We're taking the bulls by the horns here. We're saying that we don't expect additional resources to come our way. So somebody has to take responsibility for trying to create more access to care. So I think there's a lot of potential. We'll see though. If we shouldn't. We're talking a lot about the community engagement arm of this study. This is a project. We're going to see if it makes a difference if we're all involved. And I think we need to remember that it may be difficult for us to step out of our routines. And of course, I always root for community. I always do. But we're going to see if it makes a difference. So I think that's important to remember. And what we're trying to do in terms of the last category, increasing the capacity for work. There's some ideas under collaborative care for increasing capacity. Team case review. Wouldn't that be wonderful? To be able to have a group to contact, I would love to talk to a therapist about, is this medicine the right medicine? Can you take medicine and therapy at the same time? what kind of therapy? I mean, I guess there are many kinds of therapy. I'm not a therapist. There are many ways to help someone through a depression, and what's best. So team supervision might be a great way. You know, we're always trying to get access to doctors, and the nurses, my nurses are. And so having the ability, may not be a Queen's Care doctor, and to me it doesn't really matter as long as it's a team, and everybody brings something special to the table, you know, having that access.
I just wanted to take off from that because BHS has done a couple of different collaborative projects with mental health where we actually, you know, have treatment teams that meet together. They discuss treatment planning. So there's a mental health person, a substance abuse person, working together to develop a treatment plan. It may be a mental health client or it may be a substance abuse client, but we kind of trade information back and forth, and it goes along with what you're saying. What I've been trying to do is get some primary care people involved. That's quite difficult. But, you know, through this project, just imagine, like Elizabeth was saying, is if we could put together, you know, kind of some teams that could sit down and kind of do case presentation and say, you know, what do you think is the best way to handle this, or who could we refer this person to, or that kind of thing. I think it'd be pretty awesome.
Other ways? Questions or comments?
We're doing all the
capacity.
talking.
How could you increase your capacity through collaborative care?
I'm not sure about through collaborative care, but some of the ways that we're already working on increasing our capacity is to move away from individual models of service delivery into more group models, just out of primarily the need to continue to not have huge waiting lists. So, you know, that has its own culture shift with employees and values of what one believes works and what one believes is second-class service delivery and the like. So productivity numbers are embedded in that and the like. But we're sure trying to increase access by having more group formats occurring so that our productivity number isn't hurt because it's simply getting more people in the same hour.
Following with what Elizabeth was saying, and I could direct this to you or anybody in here, though, what is your feeling about collaborating not only with, let's say, with substance abuse or with, you know, the primary care doc down the street, but within a network of folks? I mean, is that something that you see your agency as being capable of doing? Is that too much for you to do? Do you see a value in doing that?
Yeah, we find it absolutely required to keep business flowing. I mean, it's the only way to do business in this century, because otherwise you end up having disgruntled clients. And that falls on you if you don't find them the help they need. So, you know, we're really approaching it both from a business venture of, you know, customer satisfaction levels as well as, you know, directly improving their conditions. So.
Good for you. I was going to say it's really hard to work with other organizations because you have your own mandate of what to do. I'll tell you one thing that we've thought of to facilitate different organizations working together. We've got sample MOUs. We recognize that, you know, for Children's Bureau to work with Queen's Care, you might need some kind of agreement, official agreement. So we have been collecting examples of MOUs, Memorandum of Understanding, to facilitate. So if we did become a partner, that we could you know, engage in an MOU. DMH right now is examining an MOU with CPIC, and it's actually going before the Board of Supervisors, I think, that they are formally a partner in CPIC, and, you know, what are the limitations on that kind of arrangement. So, you know, so we recognize there are barriers. We want to work together in an ideal world, but we have our mandates, and we have our clients that need their whatever on a certain day, and so we are going to try and facilitate. We know it's going to be hard, but we think we can do it. So do you want to say something?
My question is, I definitely see the effort in bringing all these individuals together. I think it's going to make us obviously a little bit more efficient, more effective at treating the patients. Has there been a push to go even a little bit more further and actually having some kind of knowledge, resources available so that we could try and get individuals who are affecting the patients in the same room, in the same table, talking about how to treat the individuals? Because in my my experience, for example, there's been cases where I'll have the patient, and I'll be talking to somebody else who's providing services, and I'll get information from them, but it takes just too long for me to receive that information. Wouldn't it be better to go ahead and work with these different agencies, come in like maybe once a month and talk about, hey, this is what I'm doing, how can we better assist this client? Is there something that in the works, or is it too much of a risk at this point, or what are some of the things that we...
You need to come to the community engagement meeting.
Present that idea. I mean, that's the kind of idea that we hope somebody from the community would put forward and say, why don't we work on this kind of idea? The sky's the limit. The community plan is the community plan. There's no set limit. I mean, we don't know what's going to result. But it's good ideas like that that will make a difference. So, it's hard enough to get people to the table. We're so happy we got this many people to come today to the table. So our next challenge will be creating a plan that makes a difference.
And one of the things we've kind of been struggling with, because it seems as though people want to be told what to do. Well, tell us, what do we need to do? What are we going to do? And the whole purpose of this is to bring folks together to say, this is what we want to do. So ideas like yours, we're hoping that's going to rise to the surface out of the community engagement process meetings, that somebody like you says, well, I think we'd be more effective if we had case presentations, in our mutual clients or whatever. I mean, whatever it is that would make it more effective for all of us. And that's where I see some of these resources really coming together and people starting to think out of the box a little bit about what can happen. But it's you folks. It's not going to be me or Elizabeth or Ken or anybody else or Loretta. And in fact, it's just the opposite. They're standing back saying, okay, we brought you all together. Let's hear what you have to say. So that's what this is about, is really hopefully getting all the members of the community together and let them decide what's the best thing, what's the most effective thing that's going to work in our community. And to me, that's probably one of the most exciting parts of this whole thing.
When I brought up the thing about the MOUs, people get stuck on HIPAA. Like, you're telling that plan, and I'm thinking, okay, now HIPAA, what are we going to do about exchanging patient information? And, how does my agency talk to your agency? So the study can help and support us because they help smooth off those difficult edges. So we tell the study team, can you investigate how we can overcome HIPAA issues with that? And it will happen. I mean, we have the support for that kind of thing. Or how do we make an MOU? Or, so it's nice to have that kind of support to make a creative idea work. And hopefully we don't get stuck on HIPAA or all those things that, guide our regular practice.
And a word about collaborative care is collaborative care came out of systems where different kinds of providers work in the same building. However, they were not integrated. And what happens when systems implement collaborative care is the multidisciplinary teams who are treating a patient start meeting. And that's much easier to do inside the system. So inside Kaiser or UCLA Medical Center because they're all in the same building. So the idea you propose is exactly what we're trying to do out in the community, which is build collaborative care out of many community-based agencies that may be discipline-specific. because a lot of in Elizabeth's particular program within Queen's Care is a nursing program.
Well,
It's
right.
made it's staffed with nurses.
Right.
So you're not going to get a multidisciplinary team within your program, but you're going to get a multidisciplinary team to treat a client within this environment.
And hopefully that, I mean, again, one of the ideas of this whole thing is that it will be a model for other communities. We're doing this in SPA 6 and SPA 4, but we're hoping that the results, the outcomes of this will be something that we can disseminate and that, you can put together in Lancaster, you can put together in, San Diego or wherever it's needed. Excuse me. So that's, part of this is that this is kind of an experiment. It's a pilot project. It is, I think, rather ambitious. But at the same time, it's very timely. At this point in time, for all of us, we're going to have to come up with something else because depending on that funding from the state or the county or whoever we used to get funding from is no longer an option. It's drying up quick, and it's going to be a while before it comes back, and our clients aren't going to go away. In fact, with all of what's going on, there'll probably be more people with depression. So, I think those of us that are involved in this, that recognize this and see it coming, kind of have an obligation to do what we can, and I think this is, like I say, very timely that we get together and start working out ways that we can work together and hopefully increase what resources exist or increase access to those resources.
So are we?
We're like about 2:30.
We have
Half an hour to do a song.
Yeah. I just want to make sure everybody feels comfortable with what you're getting, the resources that you're getting.
Questions about the website?
Yeah, any questions about the website or?
Can we call if we have technical difficulties?
Yes. Call,
Yeah.
this is the people you call.
Our phone is Esmeralda and my phone numbers, and most of everyone else is on the website. There is the contact forms where you can contact a particular person, or you can contact all of us. And to contact all of us, we do contacting Esmeralda and I move forward.
Yeah. And, I hope, like I said earlier, that, you come to a conference, you get all psyched up or excited about the topic and then leave and nothing happens. So I do hope that, take out that flash drive in the next couple weeks and look what's on it. Think about how it might work for you. If you are a register for CPIC. If you're not, participate if you want to participate, if you have the ability. And, call Jim or I up if you have special questions relating to your organization. 'Cause we really would like to build something. We are actively seeking new partners. So use it and look at it, and we'll help you, and we'll find, if we can't answer your question, we'll find somebody who can. So you want to make sure you feel like you've walked away with something.
And I just wanted to follow up what you're saying about coming to a conference and getting all excited and then nothing happens after that. I mean, I guarantee you things are going to be happening. If you want to be a part of them, sign up, register, and be a part of CPIC, because we will contact you and make sure you're involved and that you're going to be doing something. So that's the important thing is, I mean, it's one thing to sit back and watch all this go on, and ultimately it will probably benefit those folks that do that. But if you want to have some say in how it happens, get involved with us. And if you're not the person that can make that decision, go back to your manager, your CEO, whoever it is, and say, hey, you need to, talk to these folks. So we'll be happy to call them. We'll be happy to come out and talk about the project and what's involved, and keep the whole thing going. But we do need to keep it going. So.
This is not the study where you go home with your bag and set everything in a corner and you look at it one day and it's just as you were. Like, this isn't that study. We really, really want you guys to participate. I've been in this from the beginning, since it was Witness for Wellness, and I have watched this grow. And I guess the other thing I wanted to say is I watched me grow too. I didn't know Susan and Esmeralda and Jim and Elizabeth or Mariana when we first started this study, but I did know Susan Stockdale, who was sitting there, and she can co-sign, she can vouch how much I've grown as a person just participating in working at HAP. For example, I would have never said anything to you guys. I would have just sat here and just whatever type. But it is good for me. And the other thing I want to
teach a class at
yes,
UCLA now.
Yeah, I do.
Right?
I teach a class at UCLA. I would never have ever thought. Okay, here we go. Next step. That I would be doing something like that. But this is, and I'm going to try to learn the CBT. But doing this, even just the things that I take home, and you do have a new attitude. You guys just come on board, and you'll see the difference that you can make in your clients and in your coworkers. You can make a difference, and this is your opportunity, I guess is what I'm trying to say. I mean, how many times have you been to a conference and someone from the White House called? Mm-hmm. So this is like the opportunity. So hopefully you guys will jump on board, and whichever group you end up in, please know that it may not be the group you wanted to be in, but at the end of the day, we're all going to have the same thing, whichever works the best, and we'll be able to improve our clients' lives, and that is truly, truly important. So that was the end of my speech. But
Here, let me
okay, I'm sorry, you wanted to talk. Yeah.
I think Jose brought up a really interesting point, because the CPIC project is a resource, and trying to do something like having interagency meetings about it, I mean, figuring out how to get around the HIPAA kind of stuff is going to be ugly. And it's great if we can kind of figure out some of the steps, so we would be able to help provide some tools that when you really want to do this, when your agency is ready to try and do it, when you've identified another agency that wants to work with you, we could at least provide some guidelines so the process isn't quite so difficult, and each other agency maybe that wants to try it doesn't have to reinvent the wheel. So it's a shortcut. It's a service that I think that we can provide to assist making this easier in the community as a whole. Somebody else? This is a commercial break.
Well,
Infomercial.
Yeah.
And we're wrapping up the conference at 3 o'clock and answering any additional, 3 o'clock we'll come back together and answer any additional questions that people have. You all got 100 times better explanation of what you're walking away with. The rest of this crowd is going to walk away with that same bag. They're not going to know really what's in it. And so I really thank you for taking the time, and I hope that you use the materials wisely and it benefits our community.